keep in mind that tomorrow is a free day. So let's take a look. If we speak about viruses, we know that they are not actual living things. They are just the nucleic acid covered by enveloped sometimes not even covered by an envelope. Most of them have a capsid, which is like a proteinous structure that covers the virus. When we are speaking about the antiviral medication, these are medications that help us eliminate the viruses. How can we do that? Well, it should be something related to the virus the cycle of the virus. I want you to notice two things. In the microbiology, for the sake of the USMLE, they like too much one virus in special. So special for the USMLE, which is HIV. You must know each portion. How did the HIV affect us? How does it replicate inside of us? How does it move? What it does? You need to know all of that, because each of these steps have a drug that will be working at. So, and the other antiviral drugs, we will have to know their cell cycle as well, because each step will have something that will be working at. So, let's start with the HIV drugs. When someone gets HIV, he will be, this is the HIV virus. Is it an RNA or a DNA? Does anybody remember HIV? Is it RNA or a DNA? RNA, absolutely. Is it single-stranded or double-stranded or two strands not related to each other? Absolutely, the third option. Two RNA strands, but they are not connected to each other. Absolutely. So this here is the capsid. Remember, the B24, yes? And it was the most initial test that we ever done. And you can see out here, we have some antigen right here. And one of these antigen is helping us for attachment. Does anybody remember what helped us to attach? What helped the HIV to attach to our cells? We had, if you remember, something called the CCR5, and we had this something binding to it, which was the GB1, excellent, the GB120, and except the GB120, we also have this channel, and this channel was called the GB41. And remember, both the 120 and the 41 came basically from the same structure, which is the ENV gene of the virus. Okay, so anyway, here we go. So we have virus HIV entered the cell, attached to the cell using the 120 GB, and then it will be infused into the cell. And the thing that leads to the infusion inside is the GB41, okay? So now we have attachment. The next thing is penetration, or as people say, fusion, FU for fusion. And after that, we will have uncoating of the virus. And now what we have inside of it, we have some particles here. We have the RNA of the virus, and it has two little molecules. One of these molecules is the integrase, and the other one is the reverse transcriptase, okay? So you can see here that the reverse transcriptase work in the RNA, and what it's going to create from the RNA. DNA, absolutely, good. So it will create DNA out of RNA, and after creating them, it will integrate them inside of the genome of us, human beings. And the process of integrating them inside of us needs an enzyme called integrase, which integrate the viral DNA into our DNA. Then the process of transcription and the translation will occur, okay? So translation occurs, and now we have a new virus, a nucleic material. And then a protease, which do post-translational modification to make it look better. Remember, we used to cut the S terminal, we used to cut the C terminal and N terminal to make a good looking protein after the translation process. Now, all of this RNA with a new enzyme synthesized will all be packed in a new basically virion, and it will be released. And the process of post-transcriptional modification is happening with the proteases. So as you can see, since we have so many steps, we have so many targets for the antiretroviral therapy. For example, if they tell you about a drug that prevents the attachment of HIV into the GB120, choose Miravirac, okay? If they tell you, well, it attaches, but it's unable to fuse the nucleic acid material into the cell, say it's enfivertide used for that, which prevents the fusion. If they tell you the cell is infected, but this patient cannot develop, well, the lady is having this HIV inside of her, and we want to target an enzyme, intracellular enzyme, to inhibit that. Well, you can target the reverse transcriptase, which if you target it, it will reduce the amount of making it will reduce the reverse transcriptase activity, which will reduce the making of DNA from RNA. So also we have the integrase, which used to integrate the viral DNA inside of the cell. And if you inhibit that with all of this tigra, notice all of them has tigra in the name. If you use any of these guys, they are integrase inhibitor, and they can inhibit that. The last thing we have is a protease inhibitor, and all of them ends with the same thing. Navir. Okay? So, done. That's the overview of HIV. Keep in mind, we have here few drugs. The NRTIs and the NNRTIs, we'll speak about them in deep. Sadly, the NRTIs are a little bit older. Thus, they don't have like a typical suffix or a prefix that you can identify the drug from. You know, I mean, when we say about the tigravir, it's not a big deal. You know that tigravir is integrase. Or navir, you know, it's a protease. But if we speak about the NRTIs, they are a little bit old, so they don't have such thing. There is simply too many drugs. The NNRTIs have vir, but without tigra. Here we had tigravir. Here they only have the vir, which is located within the name. And these guys lead to nightmares. You must know about the nightmares. Okay, so that's in general how antiretroviral therapy works for HIV, which we'll be speaking about in the third hour of today. But so today, what I'm planning to finish with you guys is 1, 2, 3, 4. That's it. It might seem it's not much, but it actually is. So the other antiviral drugs do something like this. Let's say we have another virus in our body. I don't know. Well, it could be herpes, for example, or doesn't really matter. Let's say it's herpes. This virion is going to bind to its receptor, going to get endocytosed, release the nucleic acid material inside of the cell, and when it is inside of the cell, it's going to start the process of replication. Can somebody tell me what does it mean, replication? Making DNA into? Yep, into more DNA, absolutely. So we are making the DNA into more DNA, and if we utilize some drugs, we can inhibit this process. And for example, the DNA polymerase, if we inhibit it in the virally infected cells, that will be perfecto. And that's how foscarnet and cidofovir work. Also, if you inhibit the making, okay, what does DNA made out of? Can somebody tell me what DNA made out of? No, DNA is not made out of amino acid. Yep, that's correct. It's made out of a nucleotide. Okay? So DNAs and RNAs are made out of nucleotide. Okay? So this nucleotide are arranged into the virus, and they are super important. Why? Because, guys, if I alter the nucleotide and prevent the virally infected cells from taking them, can viruses replicate and make more DNA if I prevent them from getting normal nucleotide? The answer is no. So I can kill the virally infected cell, which is our cells, which is a good thing actually. So, okay, we have also guanosine analogs like acyclovir and cancyclovir, which is basically pure as gold. So this is a purine analog basically that will mimic the virus needed, and I will explain how it works by decreasing the replication, okay? Also, the guanine nucleotide synthesis, the ribavirin, the same idea, adenosine analog, the same idea, and endonuclease inhibitor, which prevent normal proofreading of the made DNA. Okay, anyway, let's say that we have a new protein synthesis. We made some protein. After that, we will have this protein that has been synthesized will have to create this capsid, as you can see, and create the virions again. And that virion can be released. Some drugs can basically lead to decreased release of the virion, including acetylmavir and zanamivir. Now, this is just in general, and I did not go into details, and if you did not get something I just said, it's totally okay, because now comes the time that you have to understand, okay? So, acetylmavir and zanamivir, these guys, they inhibit the influenza neuraminidase, which decreases the amount of the viruses that will be released from the cell. Let me tell you this thing. If we say that this is a human cell, when the virus infects the human cells, this is a virus, well, let me name him V. So V is virus. And when the virus infects the human cells, what he will do? Can viruses grow, replicate on their own, or they will have to use the human machinery? Absolutely, they must use us. They use us, they use our machinery, and after using our machinery, we start the replication process of the virus. So they make more virus. So more virus, and then it's released. Yes? So when it's released, it infects so many cells around it. Acetylmavir and zanamivir inhibit this process from occurring, which decreases the progeny virus. A treatment and prevention of influenza A and B, but you must begin the therapy within 48 hours of the symptoms. So it may shorten the duration of illness, but it does not mean that it actually treats you. It just like make the, instead of getting sick for 5 days, you will be sick for 3 days. And it's contraindicated to start it after 48 hours because what is the point? Influenza itself resolves between 5 to 8 days. Guys, which advices will you give your patient if he has influenza virus? Which advices can you give him? Hydration. Look, a lot of people know about hydration, but they don't know why we tell the patient to hydrate a lot. Well, basically, you tell him to hydrate a lot because you want him to shed the virus outside of his body much more faster, okay? And hydration helps with that. So, if we speak about this drug, this is totally new. It's the first time they add it to the book. So, when they add something new to the book, it means one of the two things. They newly discovered it, or somebody got asked about it, okay? So if we speak about this baloxavir, it inhibits the endonuclease activity of the influenza virus, RNA polymerase. So if the RNA polymerase is not working, it will decrease the viral replication. No viral replication means no what? No making of more nucleic acid. No making of more nucleic acid, no making of virus. No making of virus, we got rid of it much more quick. So treatment within 48 hours of the treatment onset, and it shortens the duration of the illness, exactly as acetylmavir and zanamivir. Well, here is the thing. Do we like to give acetylmavir to every single patient that comes to us? We don't. No, we never. We don't like to do that. Actually, the patient will be manipulating us to get it, and we will be like, no, I will not prescribe that to you because you need to build up your immunity yourself as well. Okay, remdesivir. If we speak about this drug, every one of you know it. Why we, okay, back in the time, if you ask a medical student about this, he will be like, what? But now everybody know it. Why? Why this drug is super, super famous? Yep, Covido, our dear Covido. So, first of all, this drug is a prodrug of an ATP analog. Basically, it works by inhibiting the RNA polymerase. And remember, COVID is an RNA virus, yeah? So if you give this drug, it will prevent the replication of the COVID RNA into making more RNA. So the COVID cannot proliferate. If the COVID cannot proliferate, that means that we will have less RNA production, less replication, less hospitalization. You know, like less severe disease. So do we give this drug for prophylaxis or for a treatment of super severe disease or a treatment of any patient? Choose. Only the treatment of severe one. Somebody asking, is it proven to help? The answer is yes, it's proven to help, but it has one downside. Anybody know what is the one downside of it? Anybody know why this drug is not being used widely? I mean, he's good. He's good. It works. Like, I'm not telling you that it does not. It does. Oh, yeah. Oh, yeah. Well, it's actually a really expensive drug. I mean, like, if you look at the price tag, yes, now the price has dropped a little bit. Yeah, Trump got it. Trump, when he got the COVID, I remember, like, they started him on it, especially because of his age. We like to give it for old patient, especially because in the old patient, it tends to be, COVID tend to be more of a killer. But yeah, for Trump, who cares? Trump has a lot of money, he can buy this. But the poor patient on Medkit, for him, that's difficult to buy, okay? Basically, if I'm not mistaken, I cannot find it, but I think the whole treatment cost around like $3,000 to $6,000. I cannot find it. I'm looking for it. Oh yeah, here it is. It's $2,340. Oh no. Wait a second. It's $520 per vial and $3,000 per treatment course. Okay, which is a lot of money. So you would like, well, $3,000. That's doable. Well, yeah, but why should someone pay them? And why should he get COVID in the first place? Yep. Well, it depends. If you say about the US, it's doable. But if you are speaking about somebody in like some African countries with no resources, for example, or a third world country in which the salary is like of a normal human being is $600 to $800, and you tell him $3,000, he will get some serious constipation that night. So, prodrug of an ATP analog, the active metabolite inhibits the viral RNA-dependent RNA polymerase. So, RNA polymerase, and evades the proofreading by viral exoribonuclease, which decreases the viral RNA production. Basically, to make it short for you, this drug decreases the viral replication, which lead to less chance of a severe infection. Recently approved for the treatment of COVID-19 requiring hospitalization. By the way, guys, the new first aid book comes out in 4 days, 3-4 days. Hopefully, I will get my hand on the PDF version soon, and if I do, I will send it to you. It's coming out on the 16th or the 17th, not sure. So, the next drug is acyclovir. Anybody know acyclovir? Which disease do we use acyclovir in? Herpes. Who gets herpes? No, people going to Vegas mostly, but yeah, everybody gets herpes. So, acyclovir, famciclovir, and valacyclovir. The only difference between these drugs, to be fair with you, is duration of action, and the mechanism is similar to each other. So let's take a look. The mechanism, they are a guanosine analog. What is a guanosine? Anybody know what is a guanosine? Well, some people saying that it's a purine, and the purine is a nucleotide, correct? But that was a guanine, not a guanosine. So this is a nucleoside, not a nucleotide, okay? Nucleoside, not a nucleotide. But it's close enough. So I want you to know a few points about acyclovir. I hope I will be able to find a good picture. Basically, acyclovir is super nice because it only works in the virally infected cell and it does not work anywhere else, which is a good thing or a bad thing. Well, it does work a little bit outside, but most commonly, I'm saying. It's a really good thing, which means you will have less side effects. If it was to work everywhere, that will be really bad time for us because you will have to deal with all of the side effects everywhere. So, the idea is like this. If we speak about someone who just got acyclovir or ganciclovir for this case, actually I think ganciclovir is a bad idea because the mechanism is different, so I would like to find actual acyclovir in the cell. Cannot find it, I will end up drawing it. Oh, no, good enough. So, if we speak, this is a really good picture actually. Okay, so if we speak about this patient, let's take a look. We have the following patient. He's getting acyclovir. For what? For an HSV infected cell. So first of all, it will get a kinase. What does a kinase do? What does a kinase do? What is the function of a kinase? Yes, it adds a phosphate. It adds a phosphate. Notice the kinase is adding a phosphate into the acyclovir. Who had the thymidine kinase? Who had this kinase? It's actually the virus himself. The virus himself had it. So we got monophosphorylated. One phosphate is in place. The next phosphate will be from our cells. So it's like kind of a two keys type of situation. To get the acyclovir active, you need two-step of activation. The first one is done by the virus and the second one is done by us. I mean by the cellular kinases, which will put more phosphate, okay, on it until it becomes active. When the acyclovir becomes active, it will kill the whole cell, okay? It will actually reduce the replication, but yeah, just imagine it that it will kill the whole cell. It will just destroy the DNA polymerase, which will make less replication. So let's see, first of all, since it needs thymidine kinase, which comes from a viral virus, will it be working in other cells? I mean, cells not infected. Can acyclovir work on a non-infected cells? The answer is less likely, much less likely, because I told you it's a two-key type of situation. You must phosphorylate it multiple times for the sake of getting activated. One time, the cellular kinase alone cannot do it. You should have the thymidine kinase from the virus himself. So guanosine analog, monophosphorylated by the HSV or the VZV thymidine kinase and not phosphorylated in uninfected cells, which means few side effects. So only the infected cells are going to phosphorylate it, the non-infected cells are not going to phosphorylate it, so it's a win-win type of situation. It will only work in the virally infected cells. Triphosphate formed by cellular enzymes, and and triphosphate formed by cellular enzymes. What do I mean by that? If you take a look at the picture, here is the first phosphate, and then two more phosphate were added by cellular kinases. Yeah, thus we have a triphosphate now. And that will lead to inhibition of viral DNA polymerase by chain termination. Chain termination. What does that mean? Well, basically, if you remember, we have the 5' into the 3' thing, yeah? And I told you, oh, sometimes if we wanna help this thing, at the 3' we add an OH and 3'. Yes, that's it. In this way, it just halts. It cannot keep going. It terminate the chain. And if the chain is terminated, we will have no polymerase activity and the cell will simply die. Okay, so the clinical use can be used for herpes simplex virus and for varicella zoster virus. Weak activity against TBV, thus we don't use it for it, and no activity against CMV. It's used for HIV-induced mucocutaneous and genital lesion as well as encephalitis. I need a really good student to tell me, is it HSV 1 or 2, the one that leads to encephalitis? Some people say 1, some people say 2. Yes, absolutely correct. 1 is encephalitis and 2 is meningitis. Okay, good. Prophylaxis. Oh, guys, in case of encephalitis, which lobe of the brain is the most likely to get the encephalitis? Which lobe inside of our brain? Absolutely correct. Frontal temporal, mostly the temporal lobe. And when that happens, it leads to something called the Claver-Bowsy syndrome, in which the patient have hyperorality, hypersexuality, and disinhibition. Okay? So, it's used for an HSV mucocutaneous and genital lesion as well as an encephalitis. Prophylaxis in a patient who are immunocompromised. No effect on the latent forms of HSV and VZV, which means if the herpes just was sleeping in my trigeminal ganglia, will the acyclovir help it, or it will be just a stupid idea to take it? It will not help, but it will decrease the chance of it actually becoming reactive, but it will not lead to treatment. Guys, do we have a vaccine against herpes? Okay, well, here is the thing. To be totally fair with you, the idea about the herpes vaccine, if it is existing or not, the answer is yes, they do, but it's not available for the general population, which means me and you. In the future, we will learn what does that mean, okay? But now it's clinical trials, which means it will take 3 to 5 years for it to be in the market. Absolutely correct. Yes. So wait for 3 more years, please. So prophylaxis in a patient who are immunocompromised, no effect on latent forms of HSV and VZV. Okay, so the valacyclovir is a prodrug of acyclovir and has much better bioavailability. It can, for herpes zoster, we can use famciclovir as well, which work in the same mechanism. So the adverse effect is the thing they like the most on the USMLE. Seriously, they like it the most. It can lead to crystallopathy of the kidney, which can lead to acute tubular necrosis, basically. And if the patient have acute tubular necrosis, what are you going to see in his urine? Which type of cast? The brown muddy cast, absolutely, brown muddy cast. So how to prevent this from happening in case of acyclovir? Yep, you need to hydrate the patient. Remember this viral thymidine kinase? If he's mutated, it will not be working. If he's not working, you will not have cellular kinase. Well, if he's not working, done. You know, the acyclovir cannot be phosphorylated. If the acyclovir cannot be phosphorylated, done. The drug is useless. So mutation in the viral thymidine kinase is the mechanism of resistance. Okay, so the next drug will be about ganciclovir. The mechanism, it's a guanosine analog. Well, again, the same thing. But here is the idea here. The idea here that this drug is a little bit different. Let's see why. So I saw actually the picture the moment I came to search for these guys. I saw a picture, I think, yeah, it's this one. Okay, so the ganciclovir, its work again, it needs the thymidine kinase from a virally infected cells, which get him monophosphorylated. Then we have a triphosphate, and that will lead to inhibition of the DNA polymerase, and that will lead to less replication of the virus. Okay, the same idea basically. So they write 5' monophosphate formed by the CMV viral kinase, as you can see in the picture, and the triphosphate is formed by the cellular kinase. Again, the same thing, you need a viral kinase and you need a couple of cellular kinases to make a triphosphate structure which will inhibit the viral DNA polymerase. No DNA polymerase, no DNA. No DNA, no replication. No replication, the virus gets shed out from the body much more early. Okay, done. So let's speak about the clinical use. CMV, especially in patients who are immunocompromised, also, oh yeah, the CMV is mostly in which patient, guys? Where did we speak about CMV? And I was like, oh, it's highly specific for this category of the patient. Yes, well, absolutely. The HIV and the transplant patient, absolutely. Okay. Does anybody remember what do we see on histology of these guys? Yes, the owl eyes. The owl eyes. Histology. The owl eyes. Okay. Nice. So if we speak about, no, don't be sorry. If you have an answer, just say it. Either it will be right or it will be wrong. You are anonymous. Nobody will know who you are. So the next one, it will go something like this. The CMV, especially for patients who are immunocompromised. And valganciclovir, it's a prodrug of ganciclovir, but it is better, or it has better bioavailability. Let me give you the vignette they give you about this question. Basically, the valganciclovir is used for prophylaxis before the infection starts. So it will be about a lady who has herpes, but she does not want her partner to know about it, okay? So it's not a reportable disease. You don't have to tell the man that his partner has herpes. It's not reportable. But she's like, doctor, can you give me a drug that will prevent me from getting this, how do you call this? When it's latent and it becomes reactive. Basically, this flashes of infection. But like, yeah, just take this valganciclovir and you will be fine, okay? And to be more fair with you, we have this, not the valganciclovir, but the valacyclovir in case of herpes. The valganciclovir is given for somebody who's immunocompromised and want to prophylax himself from getting the infections. So the adverse effect of the ganciclovir is bone marrow suppression, which can lead to leukopenia, neutropenia, and thrombocytopenia, and renal toxicity as well. So what we should do for this patient to prevent the renal toxicity? Okay, yes, done. So that will be hydration. That will be hydration. Nice. So the next one, yes, nice. Okay, that will be hydration. So it's much more toxic to the host enzymes than acyclovir. Again, if the viral kinase is resistant, it will be useless for us. It's the same as the cyclovir. If the thymidine kinase or the viral kinase is not working, the drug will not work, which means it's the mechanism of resistance. Okay, foscarnet, the mechanism of action of foscarnet. The foscarnet, it's a viral DNA RNA polymerase inhibitor, both of them, and HIV reverse transcriptase inhibitor. Wow, it works on everything. It binds to the pyrophosphate binding site of the enzyme, and it does not require a kinase to become active. Well, this is a good thing or a bad thing that it does not require a kinase to become active? It's a bad thing. That means that it can work anywhere, yes? So the clinical use is for CMV retinitis in immunocompromised patient when the ganciclovir fails, or in case of a cyclovir-resistant HSV. This drug, the foscarnet, works on everything, but be highly careful because we said no kinase, which means it will work everywhere. You mean that it will work everywhere? Everywhere. In the kidney, in the kidney. In the brain, in the brain. In the heart, in the heart. Well, what does that mean? So many side effects. Nephrotoxicity leading to electrolyte abnormalities, which is kind of funny. What I mean by funny, that it can lead to literally anything, that you don't have to memorize any of them. I love when this happens. So basically it can lead to hypo and hypercalcemia, hypo and hyperphosphatemia, hypo and hyperkalemia, and hypomagnesemia. Since it can lead to all of these, you don't have to memorize them. But you need to know that the electrolyte problem can lead to seizure. This is actually important. You don't need to know which one it is. So I told you that it works on the DNA polymerase. So if you mutate the DNA polymerase, it will not work. The last drug before the break is the cidofovir. It inhibits the viral DNA polymerase, and it does not require phosphorylation by viral kinase. The same idea, highly toxic because it's basically does not need a viral kinase, so it will work in all cells. So we also use it for CMV retinitis in an immunocompromised patient, and also for a cyclovir-resistant HSV. It has a long half-life, which is a good thing. So nephrotoxicity, co-administered with probenecid and IV saline to decrease the toxicity. Why? Probenecid is a drug that works at the proximal convoluted tubule. Inside of the proximal convoluted tubule, we have a channel. This channel basically does the following. It reabsorbs uric acid, okay? So normally, why we use probenecid for? We block this channel, so the uric acid is going to be trashed in the urine, okay? So you're like, okay, so why you are giving it to this patient? Basically, this patient used the same channel to kick the drug outside of the body. So if I block this channel with the probenecid, that means the drug will be more inside of the circulation. That means that the drug is going to act for a longer period of time without going to the urine, which means less side effects to the kidney, okay? So, and that reduces the toxicity. Okay, so that's cidofovir. I hope it made sense. And it's the last drug before the break. After the break, we'll speak about the HIV drug. I know that there is many drugs we are going to speak about. The hepatitis C therapy, they are low yield, but I'm going to explain them anyway. And the last thing is the de-infection and antimicrobials to avoid it during the pregnancy, and we'll be done for the day. So see you guys in 10 minutes. Okay. So we're speaking about the antiviral therapy, and now we are going to jump and speak a little bit about the HIV therapy. First of all, can you see my screen, please? Excellent. So speaking about the HIV therapy, as we saw a little bit before, you just had to recognize where it works and the side effects. Anything else does not really matter. First of all, I will give you 3 categories of patients, and actually more. And I just want your answers, yes and no. Should we give them the antiretroviral therapy, or we should not? Somebody with a severe stage HIV leading to AIDS. Remember, HIV is the infection. AIDS is when your CD count drops under 500. Should we give him antiretroviral therapy? Somebody with a CD count less than 500, should we give him the antiretroviral therapy? Yes or no? Okay. Somebody with a CD count more than 500, but he is an HIV positive patient, should we give him the treatment? The answer, we still give him. Okay, somebody who got HIV, well, he did not get HIV yet, but he accidentally stuck himself with a needle from an HIV positive patient. Should we give him the antiretroviral therapy? The answer is yes. So let me make it simple for you. You want to give the antiretroviral therapy for everybody. That's the end of the story. Any person who you even have a suspicion that he has HIV or going to develop HIV, you give him antiretroviral therapy. A pregnant lady, should you give her antiretroviral therapy? Yes, you should, because, well, not all of them, but if she is HIV positive, you should, so she will not transmit it to her baby. So the antiretroviral therapy often initiated at the time of the HIV diagnosis. The moment you have a diagnosis, start it. The moment you have high clinical suspicion, start it. If you have a patient with, well, basically CMV, Candida esophagitis, should you give it or not? Yes, AIDS defining illness. Strongest indication for the use with patient presenting with an AIDS defining illness, low CD count less than 500 or high viral load. But regardless, it's always initiated at the time of HIV diagnosis, regardless of the CD count. The regime itself contains 3 drugs, and we use them to the regime itself contains at least 3 drugs, and they must be used together to prevent resistance. 2 of them must be an NRTIs, which is a nucleoside reverse transcriptase inhibitor, and 1 integrase inhibitor at least, preferably, but you can use a protease inhibitor instead. So, as you can see, it's 2 drugs working in 2 mechanisms of action, leading to mechanism of action that different mechanism of action which lead to synergistic effect. Okay, most ARTs, antiretroviral therapy, are active against both HIV-1 and HIV-2. Exceptions include NNRTIs and enfuvirtide, which are not effective for HIV-2. Guys, I noticed in a previous class some people misunderstood me when I spoke about the HIV-1 and HIV-2. If you remember when I told you about HIV-1 and HIV-2, which one had less drug working against him? HIV-2. Which one was more common in Africa? HIV-2. But there is one, which one is more common in the US and Europe? 1. Okay, guys, now comes the thing that is a little bit tricky that I want you to be careful about, because HIV-1, yeah, it's regarding the infectivity of the organism. If we are speaking about both of them are transmitted by what? Well, sexual, IV drugs, stuff like this. But if we speak about, yes, the blood mainly. Actually, even sex, you can't think about it like as like the drugs. If we speak about, oh yeah, this is the map basically of HIV-2, this one, and HIV-1. So, I am looking for, there is one really good table, but I'm not able to find it. But the idea is like this. To make it simple for you guys, if we speak, oh, here it is, finally. Okay. So the HSV2 can be transmitted less easily, okay? And it's less pathogenic than the other one. and the duration of the infection is shorter. Okay, so that's what I wanted you to tell you about the HIV too. But if we speak about it like in the African countries, is it like, what is the percentage of people coming from West Africa with HIV? No, it's better to get no HIV at all. But yeah, so the HIV too, actually it's still bad to get it because many drugs don't work against it. Okay? So HIV-1, yes, it's more pathogenic, but still, you have so many drugs that work against it. But if you have HIV-2, but no drugs working against it, that will suck big time. It will be really difficult to deal with. So, if we speak about the next point, which is the names of the drugs, which is basically we have a huge list. And I feel really bad that you guys must memorize it. Yeah. Be careful. So, the NRTIs, NNRTIs, integrase inhibitor or protease inhibitor. Before I speak about any of these, guys, let's say, and entry inhibitors, let's say that some patient want to go and have sex with an HIV positive patient. Is there a medication that we prescribe for him to prevent him from getting the HIV? And sorry to tell you this, but is there a medication that we prescribe for sex workers to take often to prevent them from getting HIV? Yes, which one it is? Come on. Well, you can do that. It's possible. But to be fair, oh yes, Maravirak. Absolutely. The binding one. Absolutely correct. So, the Maravirak. Okay, because it prevents the binding. No binding, basically they get some form of fake immunity. Basically, not immune, but like immune. So, let's start with all of these drugs. These ones are new. Thus, they are easier to memorize. What do I mean by that? They have something in the name that tells you what they are. Basically, the NNRTIs, all of them has VIR in the middle of the name. The integrase have Tigra in the middle of the name. The protease has Navir in the end of the name. But these drugs are old. And because they are old, they are bad in memorizing, I mean. Why? Because they just named them like this without an actual goal. So, one of the first drugs that was ever discovered was zidovudine. Please write a note near zidovudine. It is safe during pregnancy. Okay? Nucleoside reverse transcriptase inhibitor competitively inhibit the nucleotide binding to reverse transcriptase and thus can terminate the DNA chain, and they lack because of the lack of 3' OH group. You cannot continue the chain. No chain. The chain will be blunted. I mean, of the RNA, and thus there will be no RNA production. No DNA production from the RNA, because remember the reverse transcriptase is converting the RNA into DNA. Yes. So if he is trunking this, there will be no creation of normal DNA. No DNA. No problemo, no infection. Okay, so this is a cure or it's a chronic therapy for the rest of your life? When we speak about the NRTIs, it's a therapy that you have to give it for the rest of the life of the patient. Guys, if you maintain a patient CD count over 500 with a HIV patient, but CD count always more than 500, will he have any problems? I mean, because of the HIV, forget about the side effects of the drug. Yes, absolutely correct. He will be perfectly healthy, but the side effects of the drugs might be a little bit bad. Otherwise, he's good. So tenofovir is a nucleotide. Tenofovir is not a nucleoside. All of them were a nucleoside, but this one is a nucleotide. So the others are nucleosides and all need to be phosphorylated to be active. which is a good thing. They get phosphorylated inside of the virally infected cells, so they only work there. Zidovudine can be used as a general prophylaxis and during pregnancy to decrease the fetal transmission. Yes, so a lady who has HIV, we would like, first of all, 1, give zidovudine before the delivery. 2, would you like to do vaginal delivery or CT? Or, C-section. C-section. Yes, C-section, absolutely. Okay, bone marrow suppression with this drug, it can be reserved if you give the granulocyte, which is neutrophil colony stimulating factor, and erythropoietin. Peripheral neuropathy can occur with this patient, and lactic acidosis, especially with the nucleosides. So everything except tenofovir, and anemias like with zidovudine. So also we have, I cannot find this drug, but there is a drug called the adenosine. I really cannot find it, but it's an antiretroviral drug. It's called the adenosine. I need to show it to you because the adenosine. Yes. Okay. You must know about this drug. Let me send you this. Why you should know about it? Because it's the only one that can lead to pancreatitis, okay? Acute pancreatitis. Write it down, please. So abacavir is contraindicated if the patient have an HLA B5701 mutation. Guys, now I need someone who's really good at this to tell me this HLA B5701, will it be presented on MHC class 1 or MHC class 2? A lot of people saying too, I don't understand why. I told you guys, if you have one letter, it will be what? I told you, we never care about the number. We only care about the letter. It has one letter. That means, yes, absolutely. It's one letter, so it's MHC class 1. If it was 2 letters, it's MHC class 2. So let's do a quick test on this. Okay, so let's take a look. If I give you something called HLA, just random stuff, ZW123, what you are going to choose? Is it MHC class 1 or 2? 2. Okay, excellent. What about if you get something, say, is saying it's an HLA T124815. 1, 2, 1, 1, 1, 1. You don't care about the number. You have one letter. That's it. Done. Okay. So the next thing, abacavir is contraindicated if the patient has an HLA-B 5701 mutation due to increased risk of hypersensitivity reaction. They basically can lead to really bad hypersensitivity reaction, Stevens-Johnson syndrome, that can lead eventually to their skin to slough off. The next drug is called the non-nucleoside reverse transcriptase inhibitor. They have ver in the middle of the name. So ver. And these drugs also bind to the reverse transcriptase, but at a different site from the NRTIs. They do not require phosphorylation to be active or compete with the nucleotide. Thus, they have many side effects, including rash, hepatotoxicity are the most common, but what they like to ask about in the exam, the fact that these can cross the blood-brain barrier and lead to vivid dreams and the CNS symptoms. And they are common with this efavirenz. Guys, please write a note now. The drugs that can lead to vivid dream, basically nightmares. 1. Antimalarial drug. 2. Non-nucleoside reverse transcriptase inhibitor. 3. SSRIs. 4. tricyclic antidepressant. All of these can lead to vivid dreams. So I'm not telling you not to give it to the patient. I'm telling you to warn the patient about it. Like when you give it to the patient, be like, look, you might get a nightmare or 2 or 3. Don't worry about it. It's not you. It's just the medication. Okay? So the integrase inhibitor, they prevent the integrating of the basically the reversed DNA from the RNA. They prevent it from integrating into the DNA of us. Remember, after the virus entered our cell, it has been converted from an RNA into DNA, and now it wants to integrate using an integrase. And all of these Tigra basically help him to do that. So we must inhibit it. So inhibit the HIV genome integration into the host cell chromosome by reversibly inhibiting the HIV integrase. They increase the creatine kinase, which can lead basically to myopathy. Okay? Protease inhibitor, Navir. So remember again that after the creation of the protein, we had to make sure, do post-translational modification of the protein to make sure that it's perfect. Okay? And to do so, a protease used to cut off the C and the N terminals to make sure that he looks fine. But what I'm going to tell you now, that basically we want to destroy that protease that does this. Why I would do that? Well, basically we are doing that to make him dysfunctional. So assembly of the virion depends on an HIV-1 proteases, which are all encoded from the BOL gene. Keep in mind that all enzymes of the HIV are encoded from the BOL gene, like the integrase, protease, reverse transcriptase. All of them are encoded from the BOL gene, which cleaves the polypeptide products of HIV mRNA into their functional part. Thus, a protease inhibitor prevents the maturation of the new viruses. Okay, we have a virus. He want to get out. For the sake of getting him out, you need to put him inside a virion, which is made out of a protein to get out. If you cannot form this protein, this virus cannot get out. If he cannot get out, you cannot infect more cells. So you are calming him down, basically. Ritonavir can boost other drug concentration by inhibiting the cytochrome B450. Remember, anything that inhibits the cytochrome B450 increases the bioavailability of the other drugs metabolized by the same enzyme. The Navirs, the protease inhibitor, have so many side effects, like hyperglycemia. Somebody told me, like, because they did destroy proteins, they destroy the insulin, which can lead to basically hyperglycemia, GI intolerance, diarrhea, lipodystrophy, a Cushing-like syndrome. If we speak about rifampin, rifampin was an inducer of the cytochrome B450. These guys are inhibitor. So the inducer is going to reduce the protease inhibitor concentration. Thus, you will use an antibiotic against DB that will not ramp up the cytochrome B450, which was the rifabutin instead of the rifampin. So the rifabutin is not as much of an inducer for the cytochrome B450 than rifampin. So we prefer him over rifampin if both of the drugs are metabolized by the cytochrome B450. Entry inhibitor, let's start with the Miravirac. It binds to the CCR5. Guys, do you remember if somebody had a mutation of MMR5, what he will have? He will be immune, absolutely. So the Miravirac binds to the CCR5 on the surface T cells and the monocytes, which inhibits the interaction with the GB120, which prevents the attachment of the virus into the receptor and inhibits the docking, so the virus cannot enter in the first place. Infevertide binds to the GB41, which prevents the fusion. Yeah, inhibits the viral entry. It can lead to skin reaction at the site of the injection, but overall it inhibits the fusion. Okay, that's it for the HIV therapy. Just know about the side effects and the names of the drugs. You will get all of the answers correct. The last one is the hepatitis C therapy, super low yield, but I'm going to explain it anyway. And the last thing is going to be these guys. So let me start with the low yield stuff because this is just garbage and I just need to get it out of our system. So chronic hepatitis C infection is treated with multi-drug therapy that targets the specific steps within the hepatitis C virus replication cycle. So the hepatitis C virus encoded proteins must be destroyed, okay? Or prevention of them being made. Examples of the drugs are provided as follows. So we have the A's and the B's and the P's. Go alphabetically. A, B, and P. Okay? Alphabetically. It's difficult to make a vaccine against the hepatitis C virus because of the antigenic variation. Okay? No proofreading, which means he will constantly have a new mutation, which basically makes it impossible for us to deal with its different shapes, different nucleotide sequence. So we cannot make an actual vaccine against it. But if we are speaking about the treatment here is targeting proteases. These proteases are enzymes. These enzymes inside of our organs are specific for replicating this virus, okay? So if we block them, there will be no virus replication. And if this virus does not replicate, he will end, okay? That's the idea of the treatment of the hepatitis C. It's actually super new. Like if you check first aid 10 years ago, it does not exist, okay? By the way, I just want to show you something. The other day I was speaking with somebody and he showed me like a version of first aid of the year 2000. It's super thin. It used to be super thin. Yeah. So take a look at this. Just check. Finish your exam as fast as possible. Because the more you wait, the thicker it gets. Okay? So, let's go to the next one. Okay, so we have something called the NS5A inhibitor and the NS5B inhibitor and the NS34A inhibitor. The alternative drugs are high yield. The drugs themselves are low yield. So the Asavir, they inhibit this guy, which is a viral phosphoprotein that plays a key role in the RNA replication. And that key role you don't have to know because it's unknown, okay? Anyway, they reduce RNA replication, which means you will have less RNA. If we speak about the other drugs, which is the Bovir, Bovir, they also inhibit some weird named protease that it's basically an RNA-dependent RNA polymerase. It's an enzyme. And it acts as a chain terminator, which means you will have, again, less RNA replication. Okay? So far, what I wanted from you to know that decreases RNA replication, that decreases RNA replication. The last one, it's a viral protease, which also prevent RNA replication. So all of these main function was to decrease replication. Okay? So these drugs are low yield. If you would like to memorize them, it's up to you. Alternative drugs, it's ribavirin. They inhibit the synthesis of a guanine nucleotide. Somebody can tell me what is a guanine? Yeah, a purine, absolutely. By competitively inhibiting the IMA dehydrogenase. So it's used as an adjunct in cases of refractory to newer medication. Guys, to be fair with you, back in the time, we only used to use ribavirin as the treatment for the hepatitis C. But now it's becoming the secondary therapy because we have much more better drugs, which is the drug I just showed you. So finally, we have the disinfectant and the sterilization. This topic, a lot of people think it's ridiculous, not important, but people get questions on it all the time, and they get them wrong because they just close their ears for 5 minutes. Super easy. Let's finish it up, be comfortable with it, and then you can just memorize it for once and never forget about it. So, disinfection and sterilization. Goals include reduction of pathogenic organism counts to a safe level. This is disinfection. Disinfection, it does not mean you have zero organism. It means like you have really low amount that probably it will not lead to a disease. But the sterilization is the removal of all microbes and their spores. Okay? So, if we speak about the chlorine and heat, both of these are sporicidals. So the autoclave is one of the best things we can do. It's pressurized steam at 120 degrees Celsius. It's a sporicidal, it kills the spores, but it may not it's not good for bryons because bryons don't really care. So if you do neurosurgery on somebody and you do autoclave, that might not work. Just it's safer to throw them away and buy new tools every single time. Okay? Alcoholics. Denature protein and disrupt cell membrane. Okay? Denature the proteins and disrupt cell membrane. Good. So let's speak about the alcohols for a second. If we have a bacterial cells, well, actually not all of the tools, but just like the head of the tools, if that makes sense. For example, if you are going to use scissors, it's preferable to dispose these scissors and get totally new ones, not to reuse the previous instrument. But I noticed that nobody do that. But actually, it is a guideline thing. It exists, but people don't do it. The fact that why we don't do it, because these Brion's disease are not famous. They are not out there. They are not like causing any type of epidemic right now. Well, at least until now. The next thing I want you to know for now is something like this. It's inside of the bacterial cell wall, we have some fat, correct? Well, to be more fair, it's cholesterol. This cholesterol we need to deal with, and we need to basically, it's located inside of the cell wall. If you put alcohol in cholesterol, what happens to the cholesterol? If you put the alcohol on the cholesterol. Well, it's correct. It will dissolve it, and that's how you kill the bacterial cells. Anyway, it's not sporicidal. Chlorhexidine and the other drugs, it disrupts the cell membrane and coagulate the intracellular component. Chlorine, this is an important one. So to be fair with you, this is high yield, this is high yield, this is high yield, this is high yield, and this is high yield. That's it. The other one's not really important. The chlorine, it's, guys, this thing we use for the toilet, the same one. It's oxidized and denature the proteins. It's also sporicidal. Ethylene oxide, it's an alkylating agent. It's also sporicidal. Hydrogen peroxide, it's a free radical oxidation. It's a sporicidal. Guys, if let's say that you have a patient with bacteria on his hand and you put the hydrogen peroxide on it, what you will see when you put the hydrogen peroxide on it? Will something happen? Something special? Yep, it will start bubbling. Absolutely, like become this foamy. Yeah, but quite cool. So that's because of creation of a lot of free radicals, a lot of free radicals. Guys, don't use a lot of hydrogen peroxide. It's not a good idea. It can lead to cancer. I know, like, for example, a lot of patients in the US, they use hydrogen peroxide for acne, like because it works. Let's be fair with each other. It does work, but it will lead to scarring and it might lead to cancer, okay? So Iodine and iodophores, halogenation of the DNA, RNA, and the proteins, it may be sporocidal as well. Quaternary amine impairs the permeability of the cell membranes. It's not sporocidals. Okay, so the antimicrobials to avoid in the pregnancy. Sulfonamide, we don't give them because they might lead to kernicterus because of the increased amount of bilirubin, especially in G6PD deficit patient. Aminoglycosides, they are ototoxic. Fluoroquinolones, the cartulage, and the clarithromycin, they can lead to a stillbirth, okay? Tetracycline, discolor teeth, the inhibition of the bone growth. Ribavirin and griseofulvine are teratogenic. Chloramphenicol, gray baby syndrome. So be careful about each drug and for which patient it's totally contraindicated. Okay, guys. So now today we finished 40% of the material of the book, which is good. And from the next class, I took a look at the voting. Next class will be starting with the GIT, easy system, important system. You will get many questions from it, but it's actually quite easy. And after that, we will see which system we will be doing. It will not take a lot of time, the GIT. Now the system will be going much faster since the longest system in the whole book was microbiology, okay? So I will be doing gastrointestinal with you. And how long will it take? For gastrointestinal, I'm thinking maybe 10 days. 10 working days. Not more. It cannot take more than 10 working days. But if we speak about the biochem, what I'm thinking I should do, and I should be serious with you guys, I must incorporate into our lesson one page per class. At least one page per class, to give you this biochem as doses. I gave you the molecular already, but the cellular is a little bit easier. So I think I will be starting to give you one page per class of the molecular, of the cellular. And by the time we finish the GIT, we'll be done with the cellular as well, and with the lab technique as well. So other than that, that's it for today. And one more thing. Guys, on the 24th of this month and the 25th, I'm taking these days off because I do have interviews. We'll see about that. Hopefully everything will be all right. But on these 2 days, 20th, 4th, and the 20th, 24th, 25th. But I will make it up for you guys. Don't worry, your classes will not be touched. I will make it up for you in another day. So, all good. Otherwise, I will see you guys tomorrow. Not tomorrow. Tomorrow is off. I will see you guys on Saturday. So, see you on Saturday.